Good afternoon, good evening, everyone, wherever you're based. We welcome you to this very, very important session. It talks about stigma, which all of us have, if you're a TB survivor, you would have definitely experienced. And there has been some— Good afternoon, good evening, everyone, wherever you're based. We welcome you to this very, very important session. It talks about stigma, which all of us have, if you're a TB survivor, you would have definitely experienced. And there has been some— Good afternoon, good evening, everyone, wherever you're based. We welcome you to this very, very important— Sorry about that. We're moving on. We're moving on talking about this very important topic of stigma. And we will be playing a video which has very interesting panel who will share with you their thoughts on stigma. Many of them have worked on stigma for many years. I'm going to introduce them very, very briefly. We have Helene Marie van der Westhuizen, who's based in the UK, who's part of TB Proof. Then we have Amrita Daftari, who we've heard many times. She's a social and behavioral health scientist, and she examines healthcare seeking and caregiving practices and has worked around the issue of stigma and stigma as a barrier to care. Then we have Amanda Mayer, who's an epidemiologist who's based out of the Yale School of Public Health. She's worked on TB projects ranging from diagnostics to mHealth interventions, and has had experience working in Uganda, Tanzania, and recently in Colombia. Then we have Suvanari Tuat from Kana organization in Cambodia, who's managing the operations and communications at Kana on strategic information monitoring and evaluation. And he has extensive experience in conducting community behavioral and biological research. We have Timothy Kiemba, who's a M&E and L professional with 16 years of experience in TB and HIV programming, has worked extensively with CDC, USAID, etc. And then we have Lim Heyong, who's a human rights advisor at the Global Fund, and we'll bring that perspective into stigma. Then we have Lisa Redwood, who's a PhD candidate at the University of Sydney, and has been working around issues of stigma in HIV. So as you can see, we have a absolutely fantastic expert panel with us, and there will be an opportunity for question and answers at the end of the video. So please feel free to put in your question and answers in the chat box. We will be following that up and take it up at the end of the video. Thank you very much.
Yeah. Hello, and thank you for joining this presentation. I'm Helena Marie. I'm a doctoral researcher at Oxford University, and I'd like to acknowledge the contributions of my supervisors to this work. As potential conflict of interest, I'm chairperson of the board of TB Proof, a TB advocacy organization. The research that I'm presenting today is based in a rural district of the Eastern Cape in South Africa, an area where I used to live and work as medical doctor. We explored the experiences of patients and health workers in preventing the spread of TB in communities. Central to this is the question, how long is someone who has been diagnosed with TB infectious? And amid the scientific community, there is debate, with answers ranging from 48 hours to 2 weeks to up to a month. And this is also reflected in the WHO TB infection control guidelines of 2019, which refrained from giving specific guidance. Through our data, we explored what happens on community level when the duration of infectiousness is unclear. Using both semi-structured and narrative approaches to interviews, my research assistant, Nomisa Somdyala, pictured on the photo, and I interviewed 18 healthcare workers, 2 of whom had previous TB disease, and 15 patients, 9 who had TB disease. The interviews were between 30 and 90 minutes each and were conducted in isiXhosa or English. Interviews were transcribed, translated, and analyzed inductively using thematic analysis. The term isifo sephepha was used in one of our pilot interviews to refer to TB disease. It was puzzling. It directly translates to the disease of paper. We asked our participants why they think it's called that and received rich and varied explanations, grouped here into 4 different categories. The most common explanation involved paper as an object. Smoking cigarettes, rolled with paper, could lead to developing TB. Participants also said that inhaling smoke from garbage incineration, burning paper, was a risk factor for TB. They noted that in their community, mine workers who are diagnosed with TB often receive a piece of paper that transfers them from the mine's healthcare facility to their local clinic. The second group involved phonetic similarities. 2 participants noted the sound of a patient coughing, so pe, 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 or the sound of the isiXhosa word that describes a persistent, irritating cough, siphepezelayo, is phonetically similar to pepper, meaning paper. The third group of explanations involve metaphors that link to paper. One health worker described the process of having TB to his patients as being similar to a piece of paper burning. You burn, so you have fever, and then it stops, meaning TB also ends. Another metaphorical explanation that was used is TB spreads like smoke from a burning piece of paper, so via the air. The final group involved translation errors, so a participant observed that an English translation may seem only partially correct, but be fully understood in isiXhosa. Prof. Pamela Maseko, who specializes in isiXhosa lexicosemantics, offered her expert opinion. She said the herb that was used to treat a cough came from the ipepa tree. So isifo sephepha becomes the disease of the paper tree. Participants then use etymological reinterpretation, where the meaning of a term is reanalyzed to resemble more familiar words, paper, instead of an unfamiliar term, the ipepa tree. Yet these are not just stories about etymology. They examine who typically gets TB, how it spreads, and what having the disease entails. It gives a glimpse into how community members have grappled with and explained the local epidemiology of TB. We explored this further, asking how infection control is managed at community level. Among all of our participants, there was significant uncertainty about how long someone with TB poses a risk to others, with the majority saying it is for the entire duration of treatment. Health workers reported seldomly providing guidance on infection control measures at home, except when the patient has drug-resistant TB. This contrasted starkly with their infection control efforts at health facilities, and they describe an invisible line that is crossed when a patient leaves the facility where they don't perceive themselves as having influence. Several health workers also expressed doubt about whether any infection control was done on community level in the absence of guidance. However, community members reported infection control measures that include giving someone with TB separate cutlery that is then washed and stored separately, living alone, and avoiding children. Again, for the duration of treatment, which can be 6 months for drug-sensitive TB or up to 2 or 3 years for drug-resistant TB. This was amplified for patients with drug-resistant TB, and that is powerfully described in this quote. "People get disgusted by me. When you enter a room, they stand up and they leave. I don't go to places anymore because I'm known for having this big illness that infects people." This quote shows how infection control practices can also be examples of enacted stigma. Through our data, we describe how people make sense of TB as an illness. This relates to the broader process of sense-making, how it shapes identity, is a social process, and influences our actions. And sense-making is something we all use in our daily lives. Understanding sense-making is important for health workers as it influences how we communicate about health conditions. If we start with different interpretations of TB, we will struggle to reach a shared understanding. It is also relevant to researchers and policymakers as it can help inform health interventions. Building on health beliefs that contribute positively to preventing TB, for example, that minors are perceived as a group that have a higher risk of TB, or influencing those perceptions that have a negative impact and are ineffective, for example, requiring separate utensils for eating. In conclusion, among health workers and patients, there is a high degree of uncertainty about how long someone with TB is infectious. This likely contributes to current practices. That means people with TB are often subjected to unnecessarily prolonged, ineffective, or stigmatizing infection prevention measures. Engaging with how communities make sense of the disease of paper is important as we strive towards lessening the burden of TB stigma and providing high-quality, person-centered care. Thank you.
Hello everyone, I'm Suvanritut from Cambodia. I have no conflict of interest to the report. It is my great honor to present our research entitled Characterizing and Measuring Tuberculosis Stigma in the Communities, a mixed method study in Cambodia. This study was implemented by the National University of Singapore and CANA, the largest national non-governmental organization providing community-based HIV and TB prevention, care, and support services in Cambodia. Let us move to the background of the study. Cambodia is one of the 30 high TB burden countries with tuberculosis incident rate of 302 per 100,000 population in 2018. Stigma is a significant barrier to healthcare and a factor that drives the global burden of TB. However, there is a scarcity of information on TB stigma in developing countries, including Cambodia. Therefore, the objective of the study is to characterize, measure, and explore the determinants of TB stigma among people with TB in Cambodia. We conducted a mixed method study using a triangulation conversion design between February and August 2019. We implemented a cross-sectional study where 730 people with TB were interviewed. We also conduct 31 in-depth interviews with people with TBs. Quantitative data was analyzed using descriptive statistics and generalized linear regression models. In this study, sell 12 items and pursue 11 items stigma by the community were measured using validated scales developed by Van Ree and college. Qualitative transcripts were systematically analyzed. This study was approved by the National Ethics Committee for Health Research, the Ministry of Health Cambodia, and the National University of Singapore Institutional Review Board, IOBs. Informed consent from participants were collected. The results show that 56% and 51% of participants experienced self-stigma and pursue stigma by the communities, respectively. We found rural traders' knowledge of how TB is transmitted and knowledge that anybody can get TB were associated with higher level of self and perceived stigma by the communities. Moreover, a higher score on knowledge of TB symptoms were inversely associated with both self and community stigma. Figure 1 illustrates participant responses to the question on self-stigmas. Among the respondents, most people agree that some people who have TB keep their distance from others to avoid spreading TB germs, whereas the least number of respondents agree that reluctance for people to tell others that they have TB because others may think that they also have AIDS. The figures 2 illustrates participant responses to the question on perceived stigma by the communities. More than 60% agree that some people do not want to with TB playing with their children, and only 4 in 10 perceive that some people in their community prefer not to have people with TB living among them. Thematic analysis reveals account of experience stigma, acts of intentional distancing and hiding TB diagnosis from others, and feelings of embarrassment and shame. One interviewee expressed that she did not dare to go anywhere to avoid people feeling bad about her. Her health condition and the risk of her spreading the disease to people around her. Another interviewee mentions that he feels embarrassment because his other acquaintances chance him. In conclusion, TB stigma was prevalent, suggesting a need for the incorporation of stigma reduction strategies in the national TB response. These strategies should be contextualized and developed through community engagement. Further research should continue to measure the level of dimension of TB stigma among people with TB through surveillance using standardized tools. With that, I would like to thank study participants, the field workers, and the TB affected communities who supported our work, my co-author, collaborator, and funders. Thank you very much for your attention and happy to take my questions.
Thank you so much. Hello there. I am called Timothy Kiemba. I work with the USAID Defeat TB project as a senior monitoring, evaluation, and learning advisor. I have no conflict of interest to report, so I'll go ahead with this. I'm here to present specifically about TB stigma in urban communities in Uganda and what the associated factors are. These are the authors for this particular abstract. Just as a background, over 50% of TB patients in Uganda experience social exclusion due to TB-related stigma. This is according to the Uganda TB Patient Cost Survey Report for 2019. TB stigma leads to TB diagnostic delays and treatment interruption, which contributes to resistance to first-line drugs and other associated factors. So as the USAID Defeat TB project, we sought to better understand TB-related stigma and its associated factors in large urban centers of Uganda. So we aim to assess the extent of TB stigma and its association with social demographics among TB patients and the general population in the large urban centers of Uganda. The aim was to guide in selection of key target groups for TB stigma reduction interventions. So in regard to the methods, in January 2019, we had a baseline assessment where through which we had a cross-sectional study of 3 districts in central Uganda. There we sampled 164 TB patients systematically and 315 members of the general population using the LQAS sampling strategy. Persons were interviewed using the LQAS, using the Van Riel Stigma Likert Scale questionnaire. Respondents with a 66.7% score or higher were categorized as having TB stigma, and those with a score below that were categorized as not having TB stigma. So in terms of analysis, we used univariate and multiple logistic regression to examine the associations between TB stigma and the social demographics. So in terms of the results, these are some of the background characteristics. Most of the respondents were actually female, 62%, below 50 years old, 84%, educated to secondary level, 44%, and had low TB knowledge, 43%. In regard to TB stigma, actually 54.9% of the persons we interviewed had TB stigma. Our focus for this study was TB stigma, but if we were to compare this with HIV stigma, which we actually was part of even what we also assessed, it was 37.8%. So pointing to the fact that the TB stigma rate is actually high, 54.9%, even when you compare it to the HIV stigma. It was also much higher among TB patients, 64.6% among TB patients, compared to 49.8% among the general population. So these are the associated factors. In regard to the risk factors, the first factor was being a TB patient in comparison or in reference to being a member of the general population. TB patients were 3.3 times more likely to have TB stigma compared to the members of the general population. The second factor was being a TB patient with low TB knowledge. TB patients with low TB knowledge were 3.6 times more likely to have TB stigma compared to TB patients with no TB knowledge at all. So actually having TB knowledge, patients with low TB knowledge were actually worse off compared to those that had no TB knowledge at all. I think this points to the fact that when one has low TB knowledge, then they have distorted or half-baked information around an issue, and probably that leads to a development of myths and misconceptions, and this also grows into some form of stigma. So I think that's the reason, could be the reason for this. The third factor was being a member of the general population with HIV-related stigma in reference to being a member of the general population with no HIV-related stigma. So members of the general population with HIV-related stigma were 2.9 times more likely to have TB stigma compared to members of the general population with no HIV stigma. So again, this is, I think, the association between HIV and TB. So persons with having TB are also thought to also have HIV. So I think basically the aspects to do with stigma around HIV again escalate towards stigma for TB. So then the other factor was basically age. Persons aged 50 years and above were less likely to have TB stigma compared to persons aged below 30 years. And this points to the fact that this is a mature age group, an age group of persons that are more tolerant compared to other age groups. Persons who are 50 years, or TB patients who are 50 years plus, were 70% less likely to have TB stigma compared to TB patients who are aged 30 years and below. And also members of the general population, age 50 years plus, were actually 50% less likely to have TB stigma compared to members of the general population, age 30 years and below. So from our assessment, gender and education level were not associated with TB stigma. So in conclusion, TB stigma was high. As I mentioned, it was even higher than HIV stigma. Yet we know for a fact that we have so many interventions that are focused on combating HIV stigma. So we need more interventions to actually deal or address TB stigma, just like how it's being done, or even much more than it's been done for HIV. The TB stigma was much higher among TB patients compared to the general population. So for greater impact, TB stigma reduction interventions should target the following. Should target active TB patients. These are the most hard-pressed, even compared to the general population. So before we actually go out to communities, I think we need to target this particular age group, this particular group of TB patients, active TB patients. We need to target persons aged below 50 years. We need to target TB patients with the low TB knowledge. We need to give them the facts in regard to the causes, the transmission, the cure of TB. Then that will build their confidence and will minimize TB stigma. We need to target community members with HIV-related stigma. So there's no way we can deal with TB stigma without combating HIV stigma. So we need to deal with HIV stigma if we are to deal with TB stigma. So this is all that I have to present. Thank you so much for listening to me.
Thank you everyone for joining today. My name is Amanda Meyer. I work at the Yale School of Public Health and the Uganda Tuberculosis Implementation Research Consortium. And today I will be talking about gender differences in perceived TB stigma in Kampala, Uganda. I have no conflicts of interest to declare. TB-related stigma is really widespread. It is thought to contribute to delays in diagnosis and even poor adherence to TB medications by changing care-seeking behaviors. We have often heard stories from female TB patients about how they were forced out of their households after receiving their TB diagnosis. However, other than these anecdotes, little is known about how gender affects experiences or perceptions of TB stigma. So we sought to compare perceptions of TB stigma in a TB prevalent community by gender. We hypothesized that women would perceive higher levels of TB-related stigma when compared to men based off of anecdotal stories and some initial interviews. We conducted this study in Kampala, Uganda. Kampala is the largest city in Uganda with 1.65 million people. Uganda has an estimated TB incidence of 201 cases per 100,000, making it a high burden country. Uganda also has a high HIV prevalence of around 5.7%, and as many as 60% of TB patients are co-infected with HIV. For this study, we nested a cross-sectional analysis within an interventional study evaluating integration of HIV testing into routine household TB contact tracing activities. We enrolled consecutive index patients at 2 public sector health facilities. Community health workers visited those who had at least 2 adult household contacts to screen contacts for TB symptoms and offer HIV testing. There are many different domains of stigma. In this study, we measured perceived stigma related to TB. We chose perceived stigma because we were aware that most household contacts were unlikely to have experience with other domains of stigma, such as enacted or internalized stigma, as they themselves are not labeled as TB patients. However, since they live with a TB patient and have seen how their community has treated TB patients, their perceptions of how the greater community views TB patients may influence their own care-seeking behaviors. To measure perceived stigma, we used TB and HIV-related stigma scales originally developed and validated by Dr. Annelies van Ree for use in Thailand. The van Ree scales have since been widely used and validated in other high TB burden settings across Asia and Africa, though as far as we know, they have not been used in Uganda before. We used the 11-question community perception subscales, in which respondents were asked about what some people in the community think rather than about their own perceptions or immediate household perceptions. The response is structured as a 4-point Likert scale from strongly disagree to strongly agree. The scales were administered in a private area of the home prior to any clinical procedures for TB contact tracing to increase the opportunity for contacts to be open and honest with their responses. At the point of analysis, we assigned basic values of 0 to 3 to each individual question, with 3 representing the strongest response and therefore the highest level of stigma. To assess the overall level of perceived TB stigma, we summed all response options, with 33 being the maximum total score. We then used a random effects Poisson regression model, adjusting for household level clustering, and used robust standard errors to compare perceived TB stigma by gender. In total, we enrolled 164 household contacts. Around 63% were women, about 10% reported living with HIV. The median age was 27. We saw high levels of stigma across the board, with women having a median score of 30 and men having a median score of 26. As a reminder, the scale had a possible maximum of 33. This 4-point difference was statistically significant when adjusting for household level clustering, with women's rate of perceived TB-related stigma in their community being 8% higher than men's. So here you can see the breakdown by individual questions. Remember, 3 represents the strongest level of agreement with the scale item and therefore the strongest perception of stigma. Women consistently reported stronger perceptions of stigma than men. The questions with the smallest difference between the genders are on the left, with increasing differences between the genders as you move to the right. Using a Bonferroni correction, there were 2 questions that had a statistically significant difference by gender. Those questions are: some people prefer not to have people with TB living in their community, and some people won't eat or drink with their family members who have TB. Our study had some limitations. These scales likely have reduced discriminatory power at the high levels of stigma we observed, as median scores were near the maximum of 3 in nearly every category. This could mean that the gender differences are even more pronounced when allowing for a higher measurement of perceived stigma. We also had a limited sample size. Our overall message from this work is that female household contacts of TB patients perceive greater TB stigma in their communities than their male counterparts. This may be because women are more likely to notice TB-related stigma occurring in their community. Alternatively, women may instead be more deeply affected by stigma, resulting in higher sensitivity to overall community-based stigma. Further research is needed to tease apart these differences and examine other aspects of stigma, such as enacted stigma, in order to understand how all of the different domains of stigma may especially affect the care-seeking behaviors of female contacts of TB patients. Our study suggests it's important for researchers and practitioners who are developing interventions targeted at interrupting TB stigma to consider differences in perceptions of TB stigma among men and women. For example, combating misinformation about TB transmission, especially in regard to food and drink, may be most effective when aimed at women. We hope this preliminary work will inform interventions to promote community-wide TB awareness and new approaches to measuring TB stigma. I want to briefly thank my colleagues who were integral in conducting this research: Dr. Mary Armstrong Huff at New York University, Dr. Luke Davis at the Yale School of Public Health, and our entire Uganda team at UTURK, including Dr. Achilles Katamba, Joseph Jita, and Joanita Njengo. Thank you very much, and I look forward to any questions during the Q&A.
I have no conflicts of interest to report. Hello, everyone. I feel really privileged to represent our team on this important work, elucidating the stigma associated with drug-resistant TB and HIV in South Africa. Now, we know that stigma and negative perceptions about TB and HIV can lead to poor health outcomes, and these can translate to people who live with drug-resistant TB and HIV as well. So last year, we conducted a study to describe co-occurring stigmas among patients who were receiving treatment for both diseases at a tertiary care facility in KwaZulu-Natal, South Africa. Our study was nested into Praxis, which was an RCT of medication adherence and social support for people receiving antiretroviral treatment and bedaquiline-based treatment for HIV and or extensively drug-resistant TB. To assess stigma and compare stigma tied to drug-resistant TB as compared to HIV, we used multiple methods. We first administered a standardized survey consisting of questions adapted from scales that had been validated to measure TB and HIV stigma, and we did this with 113 consenting patients, all of whom who were on treatment. Within a couple of days of the survey completion, we interviewed 14 of these patients to gather more in-depth insights. We really wanted to understand the drivers and manifestations of stigma and compare how people encounter drug-resistant TB and HIV-related stigma. We purposefully selected these patients based on their gender and their omission or reporting of enacted stigmatization in the survey. So here's a really brief summary of our participant characteristics. You can see they were about 54% female and aged between the ages of 20 to 57 years, median 33 to 36, depending on the survey or interview. I'm going to first discuss the survey findings, and I'll draw you to 3 sections of our survey, which had adequate inter-item reliability for enacted stigma, internal stigma, and resilience to stigma. And each set of questions was asked for drug-resistant TB as well as HIV, so we could explore if the hierarchy existed. Participants responded to each of these questions using a 5-point Likert scale. And we used emojis to enable responses that were more meaningful to participants and reflective of their experiences. What we found was that the total average stigma scores for drug-resistant TB and HIV were significantly correlated. This basically means that when people felt stigmatized, they felt so from having HIV as well as drug-resistant TB. The total scores for resilience to stigma associated with drug-resistant TB and HIV were also significantly correlated. And this likewise means that when people displayed resilience or had some coping mechanism, they did so for both illnesses. Now, participants scored higher for drug-resistant TB stigma, however, and they also scored lower for resilience to drug-resistant TB stigma compared to HIV. In particular, the scores for seriousness and risk to health were higher for drug-resistant TB, and the scores for community understanding about disease and disease prevention and acceptance were higher for HIV. Taken together, this suggests that the experience of drug-resistant TB stigma is worse, and people's skills for countering such stigma is also worse. Now, our qualitative data were derived from in-depth interviews, and this lent some depth around what patients and participants were feeling and a way in which they could express what they had already shared in the survey. We asked participants open-ended questions about negative experiences or thoughts during their illnesses. We probed around their thoughts and experiences related to drug-resistant TB compared to HIV using traditional qualitative interviewing methods. Our thematic analysis suggested that patients encountered stigma tied to both illnesses, and in their social context, having TB was immediately linked and connected to having HIV. However, there was some, not only was there some transference of negative perceptions about HIV to TB, which is not surprising given the South African context, but basically all participants, even despite the fact that there was this transference happening from HIV to TB, all participants still found it easier to talk about and accept HIV compared to drug-resistant TB. HIV was just easier understood. It was considered normal. One of the participants even used the term fashionable. Everyone knew that HIV was no longer deadly. On the other hand, disclosure, any conversations around drug-resistant TB were much more difficult for participants. It was something that was just not well understood. It was viewed to be stronger, deadlier, and generally invoked a much greater degree of shame and embarrassment. Participants encountered stigma in varied ways, and we broadly categorized these into these 3 boxes when we approached our data with existing stigma theories in mind. Overall, our stigma was driven by labeling patients as deviant, dangerous, and defiant. Enacted stigma manifested as physical separation, such as distance, differentiation of personal items, weakened relationships, avoidance, name-calling, such as low-life, burden, disgrace, useless, and ignorance or denial of support. Participants largely attributed this to drug-resistant TB, not least because many of them had already been living with HIV for many years prior to having disclosed and discovered that they had drug-resistant TB. Now, the experience or even witnessing of exclusionary acts cultivated some anticipated stigma among many participants. And this came out as a fear of disclosure, reticence around asking for help, speaking up if somebody put them down. Stigma internalization manifested as shame, self-blame, unworthiness, and this idea that they were deserving of mistreatment. A few participants even had suicidal ideations. All of this, with a concurrent fear of death, made many participants feel as if they had become non-contributing members of society and members of their family and were basically disposable or dispensable. This quote really nicely captures the different determinants of stigma. Firstly, you're sick. There's no one you're close to, your loved one, you see your family. It's just you alone plus your diseases. You just think a lot. I even told the sister next to me, and I asked and said that it's like in prison. But then again, prison is better. It just feels like you're thrown away. At the individual and interpersonal levels, the patients perceived that they were contagious and dangerous. They were worthy of being locked up. They felt non-productive, helpless, when their families generally needed them to be otherwise. At the health system level, they were constantly labeled as bad, defaulting, dangerous, defiant, without any information about where they had and how they had landed up with drug-resistant TB in particular and how they could recover from it. They were separated from other patients. They tended to be the only group of patients who were masked, or around whom others had to be masked up. Perhaps in a post-COVID era, we will see this change. At the societal or community level, their stigma was fueled by their weakened social standing. They had no social or economic protections, and any community awareness about drug-resistant TB in particular was tainted with the risk of transmission and death, as opposed to any publicity around survival and cure. When we triangulated these two sets of data, we found that the quantitative and qualitative findings lined up quite nicely. They were congruous. Stigmas related to drug-resistant TB and HIV were co-experienced, but they were also distinct and unique. Expressions and drivers of stigma for drug-resistant TB mapped onto well-known mechanisms for HIV. However, we saw drivers tied to the airborne contagiousness of TB and poorer community comprehension of the recovery process of drug-resistant TB to be quite worse. And all of this suggested that the weight of dealing with drug-resistant TB stigma could be more difficult and intense for patients compared to HIV. The implications of this research, we think, is that work needs to be done to reduce stigma and build resilience. But while counseling and family support could buffer some of the interpersonal drivers of stigma, there's a pretty obvious need that we need to build inclusivity, trust, communication in the health system, deliver more compassionate and respectful care, advocate for protections for families affected by drug-resistant TB. And this could perhaps erode some of the systemic drivers of stigma. We've seen our community awareness and rights-based approaches have mitigated stigma in communities affected by HIV. So there's no reason we can't try some of this for TB. For our part, we're monitoring changes in stigma among participants to see whether a psychosocial intervention that we're implementing at the study site can actually reduce stigma. We hope we can share those findings at next year's conference. So please stay tuned and hopefully in person. I'm going to end with this slide, which shows the wide number of people and institutions who were involved in this research, and a really sincere, heartfelt thank you to the participants of the study and the staff who assisted us with recruitment, without whom none of this work would have been possible. Thank you.
Hello, and thank you for joining this presentation. I am Helene Marie van der Westhuizen. I'm a doctoral researcher at Oxford University, and I'd like to acknowledge the contributions of my supervisors to this work. As potential conflict of interest, I am chair of the board of TB Proof, a TB advocacy organization. This research is based in a rural district of the Eastern Cape of South Africa, at a district hospital and 4 primary healthcare facilities. We chose this setting to study TB infection control, as the hospital is seen as a positive deviant in implementing TB infection control, and we wanted to explore how they overcame barriers to implementation. Existing literature also points to closer relationships between health workers and patients in rural facilities, and this could influence infection control, including the use of masks and patient separation, which may be experienced as stigmatizing. TB stigma, feeling tainted or shamed by the illness, negatively impacts people's willingness to seek a diagnosis and continue with treatment. Using both semi-structured and narrative approaches to interviews, my research assistant, Nomisa Somdyala, and I interviewed 18 healthcare workers. We aimed to recruit participants with different professions, those who played key roles in either shaping or implementing TB infection control at their facilities, and have different levels of work experience. We recruited 15 patients from facility waiting areas, 9 who've had TB disease, 1 which was drug-resistant TB. And we specifically recruited people who have been asked to wear a mask when visiting a facility. The interviews were between 30 minutes and 90 minutes each and were conducted in isiXhosa or English. The interviews were transcribed, translated, and then analyzed inductively using thematic analysis. When asking about their experiences of implementing TB infection control, health workers and patients placed a strong emphasis on masks as source control, so for people who may have infectious TB. Screening patients for symptoms and ventilation were not given the same prominence. Both health workers and patients spoke about the strong symbolism associated with wearing a mask, and in this context, wearing a mask was associated with having TB. Even patients who were still waiting for their sputum results felt that the moment they received a mask was when they were diagnosed. Health workers were particularly concerned about how this contributes to stigma, and in this example of the quote, notes that it makes people feel depersonalized. Each of the 5 facilities had a different culture of practice, selecting and abandoning different components of TB infection control. At one facility, health workers stopped using masks because they perceived that patients don't like them and that this would be a deterrent to them coming for further care. In our data, we were able to contrast what health workers thought patients think about masks and what patients said. And there, although most patients also described being seen wearing a mask as a significant and at times painful experience, they brought a very nuanced perspective, saying, sometimes it will be your turn to wear a mask and you are protecting others. And then the next time when you come to the health facility with a different complaint, then it will be your turn to be protected. So communal well-being, which they described as Ubuntu, weighed stronger than individual discomfort. In the narratives of patients diagnosed with TB, receiving a mask was a forerunner of receiving a TB diagnosis. And TB itself was also a forerunner for being diagnosed with other illnesses like HIV. But it signified a longer journey that was one of assuming a new identity as someone who is ill and who may die. We asked all our participants for advice and examples of positive practices of how TB infection control can be implemented in a more human way. That was using one of the words of one of the participants. Firstly, the core message was that it wasn't about the mask as an object, but rather the way in which the health workers communicated when offering the mask. Did they also add an explanation? Could they mention that masks are used not just for TB, but also for flu? Secondly, some of the health workers spoke about compensating for the non-verbal communication cues you lose when you can't see facial expressions. They spoke about using their tone of voice and their eyes more. Thirdly, one of the nursing participants described that within this rural setting, acknowledging someone's position in the community is important. So looking beyond the patient identity. He described how he, when admitting a patient to the TB isolation room, will take a moment to introduce the patient to the others in the ward and showing respect by introducing them with their clan name. He also placed emphasis on sharing information and acknowledging the whole person, not just focusing on the medical care, which encompasses the definition of person-centered TB care. A different suggestion from one of the patients who had TB was to ask all patients to wear a mask when visiting a health facility, not just those with TB symptoms. During COVID-19 in South Africa, the widespread use of cloth masks have certainly changed this symbolism and possibly the stigma associated with wearing a mask. Having the option of choosing a mask with a colorful pattern or a picture brings a social element to masks that previously was seen as a medical intervention. We are doing follow-up interviews as part of the study to find out more. Other strategies used by health workers during the COVID-19 pandemic, which can also be helpful for TB, is wearing a picture of the health worker without PPE on a lanyard when their face is covered with an N95 respirator. In conclusion, TB infection control practices may contribute to TB stigma, yet play a critical role in ensuring safety in healthcare facilities. Positive practice examples from health workers and engaging TB patients could assist in resolving this tension. Thank you.
Hello, my name is Im Hye-young. I'm a human rights advisor at the Global Fund to Fight AIDS, TB, and Malaria. I'm grateful for the opportunity to discuss the Global Fund support to addressing human rights-related barriers in the context of TB. My short presentation will start with a brief overview of the Global Fund strategy on human rights, and followed by more in-depth discussion on programs to address human rights and gender-related barriers, and some of the good examples on how such programs can be used in the context of TB. So the focus on the human rights in the Global Fund strategy is nothing new. Promoting and protecting human rights is one of the founding principles of the Global Fund. And since 2012, the Global Fund strategy included an explicit and clear commitment to increase its investments in programs to address human rights and gender-related barriers. The commitment continues in the current strategy with a stronger focus on scaling up practical human rights programs. So as health financing organization, the focus on human rights comes from the understanding that without addressing the fundamental human rights issues, including stigma, discrimination, breach of medical confidentiality, punitive laws and policies, we cannot achieve maximum impact with our investments to end TB, HIV, malaria. There has been great progress in the human rights discourse in the context of TB. The work was the Stop TB Partnership, supporting TB communities and networks, developing community rights and gender assessment tools, or the TB stigma measurement tools, social protection work of the WHO, and most importantly, TB communities, regional and global networks are all making great contribution in understanding rights issues in TB. However, still, the actual focus and investments on practical human rights programs is still relatively limited. You know, the overwhelming majority of the TB funding requests to the Global Fund identify stigma, discrimination, loss of job, or the breach of medical confidentiality, gasping at the facility level, or the gender inequality and inequity gender norms as a main barrier to TB services. And understanding TB as a disease of poverty, and often our most affected populations are already socially marginalized, economically vulnerable, and sometimes are in conflict of the law. Without addressing such structural barriers, our TB programs cannot achieve its maximum impact. So as part of the effort to better address human rights barriers in TB, Global Fund launched a new technical brief, as you can see on the screen. And the technical brief was developed by the TB expert working group that included representation from the TB communities, technical partners, academics, and human rights experts. So the working group developed 10 key program areas to address human rights and gender-related barriers in TB. And Global Fund strongly encourages all applicants to include and adequately fund an appropriate combination of these 10 program areas that you see on the screen. So those include stigma, discrimination reduction, medical ethics trainings, or the Know Your Rights, legal aid. And those are 10 programs that we are supporting with the Global Fund funding. So the next slide, let me discuss with you and how such programs can be used in the different contexts. So there are growing number of applications that includes efforts to address some of the human rights barriers, often the stigma and discrimination, through mass media campaigns or the raising awareness in TB. All these are really important. However, to tackle stigma and discrimination at the health facilities and communities, we need a combination of these 10 key programs. We need communities who know their rights, know where they can access legal services when their rights are violated. We need to train our healthcare workers, and including community healthcare workers and volunteers, on medical ethics and on the patient's rights. We need to work with the community, religious, and other opinion leaders to raise their awareness on TB and how the stigma and discrimination affect people's access to TB services. We need to provide legal counseling and support when their rights are violated. We also need to continuously measure the improvement of the service quality and ensure that the proper linkage to the services are made, including the legal services, when there are human rights violations in the context of TB. And to do so, we need to invest in effective, community-led and community-based monitoring mechanisms. Stop TB Partnership TB Stigma Measurement or One Impact tools are some of the useful tools that help us to do that. Training of 50 healthcare workers from 20 districts for 3 days in the hotel conference room will not really make a long-lasting impact. Such programs are not sustainable. We need to integrate rights programs in the TB response, strengthen the medical ethics trainings in pre and in-service training for healthcare workers, train your community outreach workers and volunteers in basic rights and legal literacy, so know your rights activities for the communities become part of their regular TB outreach work. So for instance, in Ghana, I list some of the examples from other countries that we are supporting. So let's look at Ghana. In Ghana, TB champions who are the members of the TB communities are trained in basic rights literacy, as well as the TB, their TB outreach trainings, and are linked to the community-led monitoring mechanism through which the cases of rights violations can be reported to paralegals and pro bono lawyers for the legal support. Through the next funding cycle, we are hoping to strengthen the peer paralegal programs and strengthening the community legal empowerment. In DRC, we are investing in the TB communities to implement Stop TB One Impact tool, which monitors the service quality, including the stigma discrimination at the health facilities, along with the stockouts and the drug side effects. So this slide is prepared through a very rapid assessment conducted internally. And this is an unofficial data, and because the data is collected manually, naturally, there could be a human error. However, this is going to be important overview of where we are investing and how much we are investing in human rights. So this data is coming from the NFM2 Global Fund signed grants. So out of 95 countries where we are supporting TB response, some 50 countries are investing programs to address rights barriers. As you can see, the overall investment level is just over 1%. Well, understanding that the overwhelming majority of our funding requests identify stigma and discrimination as a key barrier, 1% of investments going to address the major barrier to accessing TB services is not at the scale to make a difference, make an impact. And another interesting analysis from the rapid assessment is in which program areas that we are investing in. So as you can see, the investment is slightly unbalanced, that there's a lot of investments going to the stigma reduction activities, and very little is being invested in the training of the healthcare workers, or the community mobilization, or the community legal empowerment. So while we have certainly increased our investments on human rights from a previous funding cycle, we still have a long way to go. And one of the effective ways to continue to push for more focus and investments in human rights programs is through a meaningful participation and engagement of the communities in the Global Fund processes. So the Global Fund Community Rights and Gender Technical Assistance is available to the communities and civil societies to better engage in the Global Fund processes, including the funding request development, grant making, grant implementation, and monitoring phases. As a new funding Model 3 is being rolled out, take this opportunity to have your voices heard, and the programs to address human rights and gender-related barriers are included and funded at scale to ensure that TB services are available, accessible, acceptable, and in good quality for all. Thank you very much. And here I end with acknowledgement of great support that I will provide from Laura Jorgen, the the Human Rights Technical Coordinator at the Global Fund, and also Hanati, our data specialist. Thank you very much.
I have no conflict of interest to declare. So my name is Lisa, and I'm from the University of Sydney, and I'll be presenting my study on the development and validation of an MDR-TB stigma scale. As many of you have probably realised, there have been an increase in studies and evidence surrounding stigma in people with TB and MDR-TB. And multiple studies have found that stigma can have several consequences on both individual and TB control through poor treatment adherence, poor health-seeking behaviour, prolonged isolation, which can lead to an increase in psychological issues. In order to be able to overcome the stigma and mitigate its consequences, we first need to be able to measure it. There are a few scales at the moment to measure stigma in people with TB. However, the stigma surrounding MDR-TB is different, and people with MDR-TB are more likely to be affected by stigma. Therefore, this study developed and validated a scale to measure stigma in people with MDR-TB. So this study had two phases, a qualitative study and a quantitative study, which was used to evaluate the psychometric properties of the scale. I'll give you a quick overview of the qualitative proportion of the study, then I'll give you more detail on the psychometric analysis. So for the qualitative study, we conducted in-depth interviews with 12 people with MDR-TB and 7 healthcare workers. These interviews were collated into common themes, and in collaboration with stigma experts, we created 48 draft items. We then conducted 37 cognitive interviews with people with MDR-TB to ensure that these initial items were culturally and linguistically appropriate for use in Vietnam. And then from that study, we refined the items, which left us with 45 stigma-related items that were assessed. So for the psychometric analysis, we gave the survey a survey containing 45 stigma items, a TB stigma scale, a depression scale, and a health-related quality of life scale to 315 people with MDR-TB that had completed 3 months or longer of treatment. The sample size was based upon the number needed to conduct a factor analysis, which we based it on 7 times the number of items in the scale. So it was 7 times 45, which gave us the 315. This study was conducted across 4 provinces in Vietnam, including Hanoi and Thanh Hoa in the north and An Giang and Cần Thơ in the south. Trained local researchers invited eligible patients from the hospitals and clinics to participate. And all participants provided informed written consent, and they all received a small incentive. So the 5 main psychometric analyses that were performed included internal consistency, criterion validity, construct validity, reliability, reproducibility, and floor or ceiling effects. So firstly, we conducted an exploratory factor analysis, which ended up removing 31 items as they either didn't load onto one factor or they had no theoretical link between the other items within that factor. We then conducted a Monte Carlo parallel analysis, which identified 4 factors, which included guilt, social exclusion, physical isolation, and blame, which you can see in the table on the right. After this, we conducted a confirmatory factor analysis, which gave us the goodness of fit statistics, which is on the left, and which all of these met or exceeded the minimum criteria required for a scale. Finally, we assessed the Cronbach alpha for the final 14 items, which was 0.76, which is higher than the cutoff required of 0.7. To evaluate the criterion validity, we used the Van Rhee TB stigma scale to see how well our scale related to a similar construct. And our scale had a correlation of 0.499 with the Van Rhee scale. After this, we assessed for construct validity, which is how well our scale relates to other similar scales, other related constructs. So we used the patient health questionnaire to measure depressive symptoms and the functional assessment of chronic illness therapy, tuberculosis, to measure health-related quality of life. We used the Pearson's correlation for this, and we found that our scale had a positive correlation with depression of 0.47, which is what you would anticipate. As stigma increases, depression also increases. And our scale had a negative moderate correlation with quality of life, which is also what you would expect. As stigma increases, quality of life decreases. Oh, I think I went too far. After this, we assessed for reliability. So we gave 50 participants the questionnaire 1 week later, and then we compared time 1 and time 2 using the interclass correlation with two-way random effects and absolute agreement. And the interclass correlation coefficient for MDR-TB, our MDR-TB scale, was 0.9. We also developed a Bland and Altman plot, which had good level of agreement with no proportional bias. We also assessed for floor or ceiling effects, which we did not find any evidence of this. Our data was normally distributed and no one scored the maximum or minimum score possible. Therefore, our MDR-TB stigma scale demonstrated good psychometric properties. The scale proved to have a good model of fit, internal consistency, construct validity, and criterion validity. Further research should evaluate this scale at different time points to assess its ability to measure stigma across the treatment continuum. The MDR-TB stigma scale should also be evaluated in multiple settings to evaluate its adaptability and global utility. Thank you.
Thank you very much to all our panelists for that excellent, excellent presentation. I think you've done such an amazing work on presenting a very well-researched data, evidence-based presentations. And there are a lot of comments on the chat box, a few questions as well, but all of them say thank you. They say excellent presentations. I'd like to go to Amrita first. A lot of appreciation for your presentation, Amrita. I know it's very early for you. Thank you for staying with us. So your question, the first one is from Jeff Akaba, and he wants to know about what you think are the reasons why HIV is perceived as fashionable, while with DR-TB, it's perceived as sick and dirty. And then he says, is having symptoms a contributing factor as to why TB disease is perceived that way? Would you like to answer that, please?
Yeah, thanks, Lucina, and thanks. Everybody's talks were just amazing. Thank you for that. I'm really proud to be a part of the session. You know, it's not that HIV was fashionable and TB was sick or dirty. These were sort of these, you know, random quotes from one person, and so I don't want to give too much credence to it. But I will say that by and large, it was about community perceptions. The communities, the neighbors, the families in which these patients lived, from whom data were collected, it was understood. What they understood about HIV was that it had become normal, it had become usual, it was no longer deadly, it was treatable, to the extent that some people even said curable in their minds. That's the meaning they had from it. Whereas there was really no information about drug-resistant TB. All the information they had was focused on all the negative things. The fact that it was transmissible, the fact that many people die from it, the fact that many people in South Africa get locked up in a hospital because they have drug-resistant TB. So that's all they knew. So it sort of ties back to, you know, Timothy's finding that knowledge could be a resilient factor in sort of mitigating stigma, but the type of knowledge, the type of messaging that we give to patients, I think can be really crafted a lot better. So for HIV, we've somehow been able to craft these messages that, you know, it's, yeah, of course you can die from it. It is transmissible, but it's also manageable. It's also normal. You're a normal human. You can have a normal life. And then somehow in TB, we haven't had that messaging come through, that it is recoverable, it is treatable. There's better treatment available now. You don't necessarily have to be locked up in a hospital, and you become non-infectious in a few weeks. The focus is all about how quickly you become infectious, but not about when you become non-infectious.
Thank you very much, Amrita. I'd like to go to Helen Marie right now. And there's a question for you from Nona, which says, do you think because of COVID-19 measures, wearing of surgical or cloth masks will be more acceptable and less stigmatizing?
Thanks, Blessy, and thank you, Nana, for the question. I think the TB world has a huge opportunity here to change the way that masks are seen and how acceptable they may be to communities. But we need to do three things immediately. And so the first one is we need to shift messaging around masks from only focusing on COVID to saying masks help for TB and COVID. And we need to start doing that now already, because otherwise it will be sort of an add-on message, maybe after the initial COVID peak is over and people really just want to discard their masks and move on with their lives. And then we come as TB community say, no, don't throw it away. So it's something that we can incorporate now already. The second one is we need to give very smart guidelines on where to use masks for TB and avoid sort of blanket policies that said that whenever you are outside of your house, you need to wear a mask. And so already identifying where are the places where people are most at risk of being exposed to TB and where wearing a mask as source control will also contribute to protection for other people. And what comes to my mind is health facilities, taxis, sort of crowded spaces with poor ventilation. And then the third thing that we need to do is also engage with the social meaning of wearing a mask. And we've seen that during COVID-19 is the topic of masks have become incredibly polarized, not because there's something inherent in the mask as an object, but because of the meanings that people associate with it. And if we only focus on masks and the medical side of it and give the technical specifications saying it must be so many layers, clean it this way, we forget that it's almost becoming part of someone's way of life, part of your outfit. And engaging in our messaging with what does it mean to wear a mask? What message are you giving to others? And they're emphasizing sort of communal protection and solidarity would be really important. So there is opportunity, but we need to do something now already to use that.
Thank you very much. Let's move on to a question that probably Timothy can answer. The question says, did you pilot and validate the Vanry scale in Uganda before implementing during this research? I'm also keen to know if you examined perceived stigma in participants by previous TB treatment and HIV-TB co-infection. Finally, I'm also interested how we interpret stigma scales amongst men who may potentially be not as willing to admit perceived stigma. Timothy, you want to take that?
Thank you very much. Good afternoon, everyone. I'll start with the pilot testing. Pilot testing was part of what part of the standard procedure we used when we were conducting the baseline assessment. So yes, we did a pilot test of this stigma scale, and but again, we didn't make so many adjustments to it because we know it's a standard global instrument that that even now in these presentations we can see that the results are comparable when we actually use a similar sort of tool. So we never really adjusted it after the pilot, but we did some sort of validation during the baseline assessment. The other question was to do with you talked of if we assessed aspects to do with perceived stigma, but I think we never sought to assess any of those areas. TB HIV, we never went to that depth, so I guess I may not speak a lot to that. Maybe those are areas for mainly further research. That's what I would say. But when it comes to the way we determined who TB stigma, or the way we measured TB stigma, we had a cutoff of 66.7%. So how we determine that is that, the Vanry stigma questionnaire has a number of stigma leading questions. So scored on a scale of 0 to 3, 0 strongly disagree, 1 disagree, 2 agree, and 3 strongly agree. So meaning that a score of 2 and above is actually, I would say on that particular question, the respondent actually agrees to that question. So when you combine a total of, say, because it's a total of 11 questions on this questionnaire, basically someone who scores 2 and above on each of the questions averagely, it would garner an overall score of 66.7. So 22 points at bare minimum, 22 points and above would be more bending a score bending more towards agreeing to those stigma inclined questions. So then we said, okay, so if someone has a score of 66.7% and above, then that particular person actually has TB stigma. And the ones below, we say are more inclined to not having TB stigma. So that's how we actually measure that. I don't know if there's any other question I've not responded to among those, but that's how I pick. That's my response. Thank you so much.
Thank you. Thank you very much. I'd like to very quickly move on to the question to Global Fund. So, Hye Young, this is for you. There's a question on how many funded proposals include psychological services for people affected by TB, including drug-sensitive TB. And there was another question of, perhaps you could also answer this. Do you know how many countries have actually started implementing stigma reduction as part of their proposals? Thank you. Hey, can you? Yeah.
Sorry. I always find it a little technical challenge when I have to unmute myself. So thank you so much for those questions. And I'm afraid the first question about how many countries or funding requests are including the psychosocial support for the TB patients, especially MDR TB patients. I think this is really linked to very great presentation that we heard from Amrita today about the MDR TB patients and the stigma. Unfortunately, I won't be able to give you the exact figure on the number of the concept notes that includes those the interventions. But certainly, I can definitely follow up after we have done some clear about the data. But I can tell you that there are a growing number of the funding requests that does include psychosocial support for the MDR TB patients or the TB patients. Ghana is an example, Indonesia example, Bangladesh is an example. So we are seeing the increasing trends. So if you're interested, definitely please leave me an email address or something that can definitely get back to you. And in terms of the countries that are implementing stigma reduction activities, I can tell you that almost all countries have a stigma reduction component in the funding request. However, the challenge is the quality of the stigma reduction component. So for instance, using World TB Day as a way to tackle the stigma once a year is not going to be enough. You know, having training five healthcare workers once a year, twice a year in the hotel is not going to be enough. So our question is, how do we design a quality stigma reduction, comprehensive stigma reduction programs, and then fund it at scale? I think that is our challenge and the homework. Thank you.
Thank you very much. We only have a few minutes left, but I want to pose the same question to our panelists. If any of you know at the country level, if the TB programs have taken steps to combat stigma, please do jump in.
From my understanding, it's exactly what was just mentioned. It's one-off workshops. They're not necessarily focused on stigma, but they might be focused on peripheral issues like counseling and ways of sort of treating patients and triaging and referring them. You know, a TB patient is you sort of have to have been beaten up by your partner and kicked out of the house in order to see a social worker. You know, you're not seeing a social worker until something really serious is happening to you. And so I think a lot of it is about resource allocation as well. Thank you.
Thank you so much. And we've had an amazing, amazing session. And it is very distressing for all of us, I'm sure. But just to leave on a very positive note, you know, the UNSG report is out. And of the 10 recommendations, the priority recommendations of the UN Secretary General's progress report, we should be happy to note that combating stigma and discrimination is one of those 10 recommendations. So there is an opportunity for us to continue to working together so that we can actually end stigma while we try to end TB, because we know that stigma is a huge barrier to accessing care and support. We know people fall off the radar because they're scared to approach services due to being stigmatized and discriminated. And we want to thank all the panelists for their excellent, excellent presentations. And this recording will be available on demand for people who missed it. And I'm sure our panelists will also be happy to have any questions sent to them on email on this. If there are any questions in the chat that we have been unable to address because of time constraints, we will take them on and ensure that people who've attended and others who are interested get a response to that. So on that note, on behalf of my co-chair, Peter, we want to thank you all for this amazing session, and thank you, Union, for the support in making this session go smoothly. Thank you very much.